So, good morning to all of you. We had a little problem with the slides. I hope it's everything okay right now. I would like to thank the committee for the kind invitation, and we have to, on the few minutes that we have to see a lot of things regarding pacemaker implantation after a TAVR procedure. First of all, we know that after a TAVR procedure, many patients, up to 23% of them, have a new intraconduction delay or a new left bundle branch block, up to 18%, but 92% of them recover at 1 month after TAVI. And it's known that in most studies, the presence of induced left bundle branch block after TAVI does not correlate with worse survival or worse outcome regarding acute heart failure. And this is recurrent in many studies. Only a few studies report that there is a decrease in survival after TAVI and in the presence of left bundle branch block or a conduction disorder with a QRS wider than 142 milliseconds. This is a very interesting case. Here we see that they performed the strain, the echocardiographic strain, and they proved that the classic LBBB pattern correlated after TAVI procedure does not correlate with classical mechanical desynchrony that we know in patients with left bundle branch block and dilated cardiomyopathy. In fact, in this study, only 2 patients had heterogeneous contraction patterns similar to those with dilated cardiomyopathy. And every one of them had a global longitudinal strain improvement after the TAVR procedure. For the 2 patients that had the classic mechanical desynchrony seen in the left bundle branch block, we at Iliopoulos Hospital have a similar case. We had the opportunity to see one acute heart failure after the TAVR procedure with acute worsening of mitral valve regurgitation with refractory pulmonary edema, desynchrony due to pacing from the transvenous lead, and the patient was refractory to drug treatment. So we implanted acutely with a CRT device. And what is very interesting is that immediately after the switch on of the CRT device, we see how the blood pressure is increased, and actually the patient recovered fully after 3 days, was transferred in the medical ward, and in 6 days, a normal procedure after TAVI was discharged. What about pacemaker implantation? This is a very interesting review saying that although paravalvular regurgitation, that was a problem in the initial trials, in the initial studies of TAVR, this has been ameliorated with the experience of the operators. That thing doesn't happen with the implantation and the necessity of a new pacemaker. And we are far beyond of the numbers that the great clinical trials suggest about pacemaker implantation after balloon expandable or self-expandable valves. In fact, true numbers are more related with 20% in the balloon the self-expandable valves, necessity of pacemaker implantation at 0.5% in the balloon expandable valves. And this is a recurrent number even in our hospital. We have the privilege to work with a team that has a huge number of TAVR procedures, so we see an amelioration of the numbers, but of a necessity of post-TAVI implantation pacemaker, but actually we haven't reached exactly the numbers that we were expecting. It is interesting to know that the TAVI, after TAVI, the conduction disturbances occur early, at maximum 48 hours after the procedure. And that's why we are this is very helpful that we cannot, if a patient does not experience new conduction disorder after 48 hours, we are at least more secure to dismiss them or to say that he is off the hook about conduction disturbances. We also know that the conduction disturbances after the TAVR procedure are reversible and are even more reversible when compared with patients that underwent a surgical aortic valve replacement. In fact, 33% at follow-up after TAVI procedure are pacemaker dependent compared to up to 60% with surgical aortic valve replacement. And of course, if we reevaluate during follow-up the indication, the primary indication of pacemaker implantation, we see that up to 85% of the cases we find that there is no more the first indication for implantation. And this is recurrent. We know as a fact that that conduction disturbances after TAVI are reversible. This is a very recent study that shows that complete AV block the first day after the procedure recovers about 50% of the cases, and in 2 months is 78% of the cases. And we know as a fact, this is another very interesting report that says that only 1 out of 7 patients that were implanted with pacemakers due to complete heart block after TAVI, only 1 out of 7 is pacemaker dependent during follow-up. And this is one of our experiences. This is the classic patient that you will expect he would be pacemaker dependent. Right bundle branch block before, cold valve implantation, 3rd degree afterwards, but he was implanted with a pacemaker, and as we can see below, he is no pacemaker dependent anymore. And that's why the European guidelines suggest to expect at least 7 days after the procedure in order to decide if whether or not we have to implant a pacemaker. And this is why, because usually patients after TAVI are implanted earlier when compared with patients after surgical aortic valve replacement. And in our data, if we waited 7 days, we see that from 19% of patients implanted with pacemaker, only 5.5% would have actually needed a pacemaker. Let's see now which are the predictors about pacemaker implantation after TAVI. I think it's very complicated to determine which are the real predictors. Electrocardiographic findings are the pre-existing right bundle branch block, the left axis deviation, the 1st degree AV block, or an HV interval at the EP study more than 52 milliseconds. This is a very new study reporting that a simple sum of the duration of the PR and the QRS interval before, after, and the change between them can predict the necessity of pacemaker implantation. And probably this is one of the indications that we should use in the future, because it seems very easy and can predict very well the necessity of permanent pacemaker implantation. But let's see other facts. When we perform a TAVI procedure, there is most definitely a mechanical trauma that depends on various factors, such as the implantation depth, the balloon used, the radial forces. And of course, we have a mechanical stress to the supravalvular region, a local inflammation, and we also might have some microembolisms of the conduction system. This can create a local damage on the conduction system that might be reversible. I think it's more useful to know regarding the procedure itself. It's a known fact that the self-expandable valves are more likely to perform a damage greater and non-reversible when compared with the balloon expandables. And it's very interesting to see that the technique itself, that the second post-dilatation is always associated with a non-reversible complete AV block. There are also some non-modifiable causes that can induce conduction abnormalities and necessity of pacemaker after TAVI, and that is, first of all, the pre-existing conduction disorders, the anatomical variability that is observed. For example, an AV node that is localized on the left heart instead of the right heart, A distribution of the calcifications, in fact, many studies now report that the distribution of the calcifications, as seen in the CT scan, can predict the incidence of pacemaker implantation and, of course, the geometry of the LVOT. And this is very interesting. It's the first report, but I believe it's something that we should consider, is the medication assumed by the patient before the procedures. Many patients, as they have many comorbidities, use beta blockers, calcium channel blockers, amiodarone or digoxin, and other drugs that might produce a certain degree of damage in the conduction system. So, as suggested, I believe that if we can stop these drugs at least 1 or 2 days and wait to restart them after the conduction abnormality, if seen, and wait at least a couple of days before, I believe that we will reduce the number of pacemakers implanted. But if we implant a pacemaker, what happens to the patient? There aren't any homogeneous results, but most of the reports say that the implantation of a new pacemaker in a patient that had a TAVI procedure does not influence the survival or the cardiovascular mortality or the overall survival. This is particularly interesting because this study says that an old pacemaker, meaning a pacemaker that was implanted prior to the TAVI, is correlated, as a matter of fact, with a lower mortality and survival rate. This is another very interesting study reporting the same thing, that in the overall population, patients with a new pacemaker after TAVI do not have a difference incidence in survival rates or mortality rates or reacutization. But it reports that if a pacemaker, a new pacemaker, is implanted in a patient with an ejection fraction lower than 50%, he has a lower survival when compared to a patient with a TAVI procedure, lower ejection fraction than 50%, but without a pacemaker. And this is something that we should consider when we decide to implant a pacemaker in a patient after a TAVI procedure. And these are the classic things that we used to speak about in various TAVI meetings. But we have more things to consider. One is the cost. The cost of pacemaker implantation after TAVI increases the total cost of the procedure about 13%. There are some cases that the necessity of pacemaker is not correlated with the TAVI procedure itself, but it's unmasked during the follow-up. The first one of them is the paroxysmal AV block. A paroxysmal AV block does not have anything to do with the procedure itself, but we happen to find it during follow-up. And of course, there are many reports nowadays in literature about late pacemakers. We cannot consider the implantation of a new pacemaker 3 or 6 months after TAVI correlated with the procedure itself. And another case that we see many times at the IEA hospital, it's the sudden death. Sometimes patients after TAVI experience ventricular arrhythmias that might conduce in a sudden death. This is a case of a relatively young female that was implanted with a pacemaker due to first-degree AV block and left bundle branch block with huge PR intervals and huge, very wide QRS duration. She actually didn't need a pacemaker, as we can see from the graphics, but she suffered sudden cardiac death from ventricular fibrillation, as we see from the report. And this is another patient that had an old pacemaker, a pacemaker implanted previously from the TAVI. After the TAVI, he experienced a ventricular tachycardia, symptomatic. He had a syncope. He was implanted with an ICD, and we can see that many times afterwards the ICD was treated efficiently the ventricular arrhythmias that occurred. And this, nowadays, it's recurrent in literature. Many new studies report that there is a fact of sudden cardiac death after TAVI. I believe it's very interesting, the one that the researchers found out that there is a deficient recovery of the QT dispersion after TAVI when compared with patients performed the surgical aortic valve replacement, but we should consider a fact, this is not related to the procedure itself. It's related to the fact that most probably the patients that underwent the TAVI procedures were older, had a burden of aortic stenosis much longer to their myocardial tissue. So the fibrosis and the conduction disorders were not reversible as, for example, a patient that underwent a surgical aortic valve replacement in earlier stages of the disease. In conclusion, I would like to believe, to my opinion, that we probably implant too many pacemakers and too early. Till now, we don't have a particular electrocardiographic finding that could guide us to the necessity of a pacemaker. We know that previous LBBB can predict the necessity of pacemaker, but not in all cases. The prolongation of the PR and the QRS interval and the sum of them can predict the necessity of a pacemaker. The self-expandable valves versus the balloon expandable valves have an increased risk of a necessity of a pacemaker. The procedure itself, especially the second dilatation, can increase the risk of pacemaker. Every conduction disorder that we find after a TAVI implantation is, at 70% of the cases, reversible. I want to say something regarding timing of implanting pacemakers. There is no formally studied when we should implant a pacemaker after TAVI. The European guidelines suggest 7 days of wait after the procedure. The American Heart Association guidelines do not suggest a particular timing. They suggest only that the patient should be implanted with a pacemaker after the procedure before discharge, if this is necessary, without specifying how many days the discharge should be. So I believe that a formal trial regarding the timing of implantation should be performed. I believe that we should eliminate and start considering eliminating all reversible causes that may cause conduction disorders prior to the TAVI implantation. We should always remember that it's not all TAVI's fault. Not all pacemakers are correlated to the procedure. In most of the cases, the new left bundle branch block induced by the TAVI procedure or the implantation of a new pacemaker does not influence the prognosis of the patient, but only in a small number of cases might increase the morbidity and mortality. And we should always remember that ventricular arrhythmias and sudden cardiac death may occur after TAVI in particular fragile and delicate patients. Thank you.
Dr. Papavasileiou, it was really an excellent talk, an excellent review on this particular subject. And there is room for a discussion, a short discussion or comments. Dr. Chlorogiannis, do you want to make any comment on this topic?
I would like to congratulate you for the excellent presentation. Indeed, this topic is very interesting, and I think that some more extensive study might reveal more subgroups of interesting about this procedure. For example, you mentioned very nice that also the accumulation and the distribution of calcium around the leaflets and also around the aortic annulus plays an important role. I would like to emphasize on this, saying that in the specific group of patients, including those patients who have a larger amount of calcium, specifically at the most critical point where there is the fuse of the non-coronary cusp with the right coronary cusp. If there is a lot amount of calcium at this specific point, do not try to do a balloon. If there is a more than average calcium at this specific point, then I would say that we have to inform the patient before the procedure that this patient has an increased risk for pacement implantation in the comparison with the others. Also, we mentioned about sudden death. This is the Achilles heel of TAVI. And I'm afraid that in the studies to come will be more increase. I would like to ask you, all those patients who had sudden death, did they check for, in autopsy if they had left main occlusion? Because also left main occlusion gives this the same picture.
Okay, so we had only 4 patients that experienced, 1 patient a sudden cardiac death, the female I showed, and 3 patients that experienced VT registered on the pacemaker follow-up, syncopal VT. So we had only 1 sudden death and 2 aborted sudden cardiac deaths. All patients, but 3 patients were affected by coronary artery disease, but all patients were treated accurately. So in reality, they didn't have an acute coronary syndrome as much as we can know. Why I say they didn't have an acute coronary syndrome? Because this didn't occur the first day, the second day after TAVI, so we cannot say that it was an occlusion of the left main due to calcium or due to the predilatation. I believe Kostas can say that. This occurred many days afterwards. So I don't believe that it was related to the procedure itself, but to the myocardial damage that was performed. My personal opinion is that these patients, after suffering for many years of acute from aortic stenosis, they suddenly feel good. So they increase their level of activity. Probably they increase also their level of catecholamines. And if you increase the level of activity and adrenergic level in a myocardial tissue that is not good, probably with a scar, probably a ventricular tachycardia may occur.
Short question, short answer. Don't you think that we should take into consideration not just the LBBB, but the simultaneous appearance of PR prolongation? It's another very important ECG finding.
During the years...
Very short answer.
Yeah.
What does it mean? What does that mean?
Okay. Initially, we started implanting pacemakers even in patients that had a prolongation of the PR interval with an wide LBBB. During time, we stopped implanting pacemakers in these patients, and we started implanting pacemakers only in patients with complete heart block. I believe, as I said, that this was a very interesting case presentation of 2019 that says that the PR incremental of the PR and the QRS and the sum of it can predict the necessity of
And second, it is not disturbing the finding of the new low-risk trial Evolute with an incidence of 17% of LBBB in low-risk patients? LBBB incidence?
Yes, but
in the latest low-risk trial of Evolute was not so reassuring.
It's not reassuring, but
did you expect this incidence with the new Evolute for LBBB?
I'm not particularly concerned about the new onset LBBB, only in a few cases, because I believe it doesn't cause a desynchrony.
Thank you very much. So we will proceed.